from morning we had a lot of discussions on gram-positive, gram-negative organisms, including the resistance pattern and its management. So now we have a different move. So now we have a talk on melioidosis. This is one of the specific infections which you see now specifically in the rainy season. I think this is the right time that we are discussing on melioidosis. It so happened in the last 1 month I have seen 3 cases, I have diagnosed 3 cases of melioidosis and managed. And you have acute presentations and chronic presentations where it can mimic also tuberculosis. So now you have to discuss on this topic Professor Nicholas, who is going to give us a rundown on the melioidosis. Over to you, sir.
Good afternoon, everybody. Thank you very much for the introduction. And I'm going to talk about something which a lot of people in this room know a lot about. So bear with me. I'll try and talk about it in a way in which hopefully we can all contribute in the future in terms of research and collecting data on melioidosis. It's post-lunch. I'll try not to put you all to sleep, but I won't mind if I see your heads nodding. I do understand. I've been there. Right. Okay, melioidosis. Here we go. So why am I talking about melioidosis? So I work in MORU, the Manipal Oxford Tropical Medicine Research Unit, and the director before me was Professor Sir Nicholas White, in the front row there, and in 1986 he decided that he would investigate this very serious form of sepsis that was afflicting rice farmers in northeast Thailand in epidemic proportions. So there we are, Ubon Ratchathani province, and the city itself is where it has a provincial hospital, Sampasipasong Hospital, and we've been working there on melioidosis since 1986 as a unit. This is just a graph of the patients that we've seen, in which the microbiology department in Sampasit Hospital has diagnosed over the past few years, and you can see that we see a lot of melioidosis. That's about 400 cases a year, culture-positive cases. So this really is one of the melioidosis hotspots of the world. But in fact, it's all over northeast Thailand. The other hospitals and the other provinces around there see lots of cases as well, and the mortality rate is still quite high. So this is just a quick primer. Many of you, most of you probably will know all this. So melioidosis, it's caused by an environmental organism, gram-negative, oxidase-positive bacillus, Burkholderia pseudomallei, and it's in the soil and the water of paddy fields in northeast Thailand, in the soil elsewhere, and it's got a number of challenges associated with it. It's difficult to diagnose in terms of it's often missed. Although the bug is quite sturdy when you culture it, often it's discarded as being a contaminant. The presentation is a great mimic. As you say, it can look like TB. Sometimes it can act like disseminated Staph aureus disease with multiple abscesses and relapses months later. So it's quite a challenge to treat clinically. And in terms of antibiotic treatment, it's naturally multi-drug resistant, and so that's a challenge as well. And you've got to treat it for a long time, because like Staph aureus, it can come back, and it's something which can actually come back decades later. In fact, it can arise for the first time decades later. So like Staph aureus, you have to treat with a prolonged course of antibiotics to make sure you've eradicated the infection. This is the bug itself. This is the slide from Susie. Susie, by the way, who we talked about with reference to AMR, she's also an expert on melioidosis. And so if you want to talk to her afterwards, she's involved in developing a vaccine. More about that later. And this slide I pinched from her. So it's an interesting bug. It's got 2 chromosomes. It's got a very dynamic genome. There's lots of recombination and genomic islands. And of course, a clone, which has then lost lots of genes of Burkholderia pseudomallei, is Burkholderia mallei. So really the name should be reversed. This should be Burkholderia mallei, and mallei should be pseudomallei. And that's the cause of glanders, which doesn't live in the soil. It lives in horses and other animals, although it can be transferred via soil. And of course, there are other Burkholderias as well, which is related to. And there are various different factors that lead to someone getting melioidosis. Some of them are host. If you're immunocompromised, you're much more likely to develop melioidosis. Diabetes is the really big risk factor that we see, but also renal disease, chronic renal disease, steroid use, immunosuppression due to cancer, just getting old, and alcohol excess also have been associated. And there are some genetic predisposing factors as well, which have been determined to do with the innate immune system. That's the host. On the bug side, there are some features of the bug which seem to be associated with virulence as well. I'm not going to go into those. And the other thing which determines whether or not you get melioidosis and whether you get bad melioidosis and the outcome from the disease is the infecting dose of the organism. Again, more about that later. This is a slide from Susie. There she is. This is a cohort that she collected of patients up in northeast Thailand. And the reason I show this is to show that of these continuously collected, the instant cases of melioidosis, 65% of them had diabetes. And the overall mortality was 34%, 28-day mortality 27%. And it doesn't seem to be worse if you have diabetes, or better for that matter. But people with diabetes have a 12 times increased risk of melioidosis in our Thai population. And of course, people with more and more people are developing diabetes. There's increased obesity, and the treatment of diabetes is getting better. So people are able to go out into the rice fields for longer, so that might be one of the reasons why the number of cases that we see has increased slightly over the years, not just better diagnosis. So this is just some data on melioidosis in northeast Thailand. Again, increasing age of the rice-growing population, increased diabetes, and increased recognition of melioidosis are all led to this to Burkholderia pseudomallei infection, melioidosis being one of the most important causes of death at a population level in northeast Thailand. See, this is old data, but it hasn't really changed very much. If anything, the position is the same. AIDS has probably come down, but you can see that it's on a par with tuberculosis. It's the second or third cause of, most important cause of infectious disease death. And the mortality in northeast Thailand has been pretty constant over the years, maybe reduced a little bit, but often patients come in, are crashingly septic, they don't reach hospital, or they die soon after getting to hospital. How do you get it? It seems fairly clear that it can either be inoculated through scratches or through the skin somehow when you're in the paddy fields as a rice farmer, not wearing any protective clothing. They don't wear boots, bare feet. Inhalation, which can be important during rainstorms, for example, where there's aerosolized paddy field water containing Burkholderia pseudomallei, and we know that you can get it from drinking water, and drinking water supplies in Thailand are often contaminated. That happened automatically. That was interesting. Anyway, so just to go back a few years, this is a before and after satellite picture of the same area of coastline in the south of Thailand, in Khao Lak. So this was before the tsunami, the 2004 tsunami, and after. It's a terrible disaster. Many thousands of people died in this piece of coastline. And of course, it was a big disaster in Sri Lanka and India as well as in Indonesia, of course. And after the tsunami, this is just some pictures of the havoc that was wreaked. And of course, people were in the flood water, the tsunami water. Everything was churned up, soil was churned up, buildings were pushed down, bits of wood. People were injured as they floated around in the water that came in with the tsunami. And a few people got melioidosis. We don't normally see melioidosis down in the south of Thailand, so we're interested in this. And they probably got it through aspirating seawater that had been contaminated with the soil from the land. So we went to see whether there was any Burkholderia pseudomallei in the soil. So a team of people went down there, and it's quite a long way south, as you can see, and sampled the soil. And you can see there where the patients were found when they were when the tsunami had receded, and where the soil sampling was. And we then compared it with a number of cases, 22 cases of aspiration melioidosis from the northeast of Thailand. And this is generally people who, the sort of standard story is somebody is a little bit worse for wear, with having had a few drinks, and drives their motorbike into the paddy field, ends up aspirating a whole bunch of paddy field water. They do very badly. See, there's the mortality rate's quite high in aspiration pneumonia. So anyway, that's our comparator group, and you can see that in the northeast a bit younger, because they're people drinking and going off the side of the road in motorbikes. And also they got their melioidosis much faster. And why was that? They also were much more severe after they got their melioidosis, and their mortality was higher. The in-hospital mortality was 64%, whereas those that got their melioidosis through the tsunami, only one died. So much lower mortality, barely significant, much less severe. When we looked at the soil, so this is, if you look at soil in Ubon Ratchathani from paddy fields, you can see how much, if you look at the last line, the concentrations of Burkholderia pseudomallei are very high, and the frequency with which soil samples are positive, look at the second line, also quite high, 20% of samples. And those that were positive, that's the concentration. Whereas down in the south, where the tsunami was, much lower. You can see that it's present, but at a much lower concentration. So this difference in severity of melioidosis was probably a dose effect, the amount that they inhaled. Mentioned that it's difficult to treat. It used to be treated with conventional therapy, doxycycline, chloramphenicol, and cotrimoxazole, and that people did very badly with that. Then ceftazidime was introduced, and this is a clinical trial that was done by Professor White in the 1980s, and I think it's one of the few, I think probably, it's the only trial I know where the introduction of a new antibiotic led to a halving of mortality from an infectious disease. So dramatic improvement. Still, if you're not treated promptly, mortality is still quite high. We generally give 2 weeks of initial intravenous therapy, and then another 12 to 20 weeks of oral eradication therapy with cotrimoxazole. In most parts of the world where we're not highly alerted to the presence of melioidosis, which I think you are here now, many cases are undiagnosed, and what you see is the tip of the iceberg. And this is a paper written by David Dance back in the early 90s. I think he's absolutely right. Melioidosis is much further, is a much bigger problem over a much bigger geographical area than we thought. One of the reasons is that it's difficult to diagnose. First of all, you need to have blood cultures, you need to have and pus cultures, and you need to have microlabs. And many parts of the world don't have enough microlabs. In Indonesia, they're particularly rare. Thailand happens to be quite good in terms of microbiology laboratory provision. The microbiologists need to be trained. They need to know that they shouldn't discard funny pseudomonads as contaminants. And if you have selective, if you know that it's a possibility that there's melioidosis, having selective media, antibiotic-containing media like ash downs, increases your pickup rate as well. There is a problem that's recently reared its head over misdiagnosis. With the introduction of Melioidosis around the world, which are, of course, as was said this morning, they're wonderful, wonderful things. They're expensive to buy, but extremely cheap to use, and they've transformed microbiology in many, many parts of the world. However, they rely on comparing the signal to a database, and in their wisdom, the US have, because of their select agent program, biothreat concerns about Burkholderia pseudomallei, it's been removed from the standard database. So it will show up as this is with the Brooker machine at least. It shows up as Cepacia. I was talking to the Brooker vice president a few weeks ago about this, and he said, well, we're not allowed to use this database unless the customer has been passed by CDC or somebody in the States. I don't know what the situation is in India, but there's a separate database which contains Burkholderia pseudomallei and other biothreat agents. It just seems crazy that you're not allowed. I wasn't allowed to look at what bugs were on that database because, in fact, somebody almost rugby tackled me when I was trying to look at somebody else's iPad, which had the list on. They're very, very worried about it, and it's just it's crazy. It means that you won't be able to diagnose biothreat agents in a standard lab in the US because they're not allowed access to the proper database. There's a nice review by Direk and others in Nature, Direk Lermathiroxican, in Nature Reviews Disease Primers last year, which goes into some of the sort of landmarks in the development of the melioidosis story. I'm just going to go over one or two of those, which are recent ones. As I was mentioning, it's a tier 1 select agent, according to the US authorities. But of course, it depends. Country to country, it varies. So but you've got to be aware of that, follow your local guidelines. So we have to handle ours in a BSL-3 lab, which is select agent certified, but only because we want to be able to collaborate with the US. In Thailand, you don't have to have that special certification, just got to be in BSL-3. So be aware of your local guidelines. And this is a study that came out about 5 years ago now, looking at whether or not doxycycline, which is what we were down to using TMP-SMX plus doxy, but quite a lot of patients in the oral eradication phase were getting side effects from this. So we dropped the doxy, see whether it made a difference in this non-inferiority trial, and it didn't. It's safe. So we just use single, trimethoprim sulfamethoxazole on its own for 12 to 20 weeks. We're now seeing whether that makes a difference. But at the moment, it depends on case to case. We generally try and do at least 12 weeks. And if it's been a serious case, we'll do 20. How did it get here? How did it get everywhere? It's quite interesting. Using genomics, you can tell a story. And this is Claire Chua-Preacher, who is a postdoc now in Moru in Thailand. She was working for the Sanger in the UK when she did this work, looking at a whole collection of strains and working out what the history of the strains from all over the world, what the history of Burkholderia pseudomallei, which sort of spreads in the soil, where it travelled. And it seems that it started in northern Australia, which is an endemic area. That's the origin. And then it spread. And it spread to India and then to Africa. And then it probably went with the slave trade across from Africa to South America, because those strains are very similar, and they're about 250 years separating them in terms of molecular clock. Dirac has also tried to model the burden. You know, we like trying to work out what the burden of disease is, and he took a whole bunch of geolocated records from all over the world, 22,000 of them since 1910, and then he put together with other data. This is a modelling exercise, so this is data about environmental suitability, population, and incidence, and did the modelling and came up with a map of where the burden of disease is. And he estimates that there's roughly about 90,000 deaths a year from melioidosis worldwide, but it may be up to 200,000, maybe a lot less. And if you look at where the burden is, the biggest burden is here in terms of absolute numbers. 44% of the global burden is in South Asia. This is modelling. It may be wrong, just to say, but on the other hand, you keep finding it, so it may well not be. And Dirac and others in the International Melioidosis Society, and Susie's in this as well, have put together a melioidosis.info website where people can see where cases of melioidosis are, where it's got case reports and papers and trials, but also it's since 2016 you can also self-report, so you can put stuff just like in ProMed. You can, if you've seen cases, you can add it into the database so that people can see where melioidosis is, and you can download from the website SOPs, lots of these posters and things, lots and lots of information. It's like a peer support group for people interested in melioidosis around the world. It's mainly in Asia, that's where the heartland is, but anybody is welcome. And Dirac and others, David Dance, have worked on this book, which you can download free, Global Burden Challenges of Melioidosis, that came out last year. I highly recommend this. And I'm not going to talk about vaccine, because you'll have to go to one of Susie's talks for that, but would it be worthwhile doing? And this again is a modelling exercise, looking at it's a health economics modelling, looking at cost effectiveness. And it seems that if you target, in most countries, if you target diabetics over 45 with a vaccine that was at least 50%, these figures, these graphs are about 80%, but at least 50%, then in most countries such a vaccine would be cost effective. This is the incremental cost effectiveness ratio over GDP in the bottom here. So you can see in India it would be cost effective. Just in Saudi Arabia it wouldn't, but that's because I'm not quite sure why that is, but in most parts of the endemic world, vaccinating diabetics would be effective. So it's an important cause of deaths. It's often misdiagnosed, and modelling estimates suggest that nearly half of all cases are in South Asia, and that a vaccine would be useful. Thank you very much.
Thank you, Professor Nicholas, for an excellent presentation. It's open for discussion. Any questions from the floor? I will ask one or two questions, or at least I had one or two incidences of a rare presentation of a melioidosis. I had an ascitic fluid which was culture positive for melioidosis. That patient had a cirrhosis of the liver with spontaneous bacterial peritonitis, spiking fever. We were wondering what is the cause.
And
then the culture grew Burkholderia pseudomallei. Then the patient was treated and patient completely recovered from the problem.
Fantastic.
Yes. Then one more was CNS. Patient presented as a diabetic, is a farmer in the rainy season last year who had altered sensorium, neck rigidity, all features of a meningitis, and the CSF culture grew for Burkholderia. So that patient also treated on the standard meropenem, he recovered and went back. And last month I had a rare presentation of a pyelonephritis. Actually, patient admitted with fever in the urology ward for stenting because he had a calculus. And the patient continued to spike fever. They were not able to find out what was the cause. Though finally patient got shifted to the medical ward. And we discovered that patient had 1 month fever and it was a melioidosis. Both blood culture and urine culture grew Burkholderia. He is a diabetic, treated, he recovered and is still on treatment and discharged. So there are rarer sites where ascitic fluid, CSF, urine, all can grow the Burkholderia.
It's an extraordinary infection and one that's absolutely fascinating from a clinical perspective.
Joint aspiration, pus, very commonly we get it. We had 1 or 2 had a liver abscess and a splenic abscess. That also turned out to be Burkholderia. I think our lab gives us the very good result. I had to congratulate our microbiology department because they give us the very fast report and tell us that it is Burkholderia. So we do get good cooperation from the microbiologist. What do you do if a pregnant lady develops melioidosis as far as the drug is concerned? Because cotrimoxazole and doxy both are not allowed in pregnant women.
You probably have to use coamoxiclav,
Coamoxiclav.
Yeah, because that has pretty good efficacy. We did do a study comparing it with ceftazidime, but it was non-inferior, but not in terms of mortality. It will work, and it's been used for oral eradicative therapy as well.
Why these diabetics are attacked more commonly by Burkholderia? Any reason?
Going to hand
12
that one
times
over. I'm going to hand that one over to
all my patients whom I have seen, everybody is a diabetic.
Every single one is a diabetic.
I to see one non-diabetic.
Yeah. Yes.
Any reason?
Susie, it's just behind you. She's going to answer.
Thank you for the question. It's a research interest of mine. I mean, as we all know, diabetes increases your risk of most infections, but usually 2 to 3-fold. So this 12-fold infection risk in diabetes is unique to melioidosis, and it's probably a number of levels. Your neutrophils don't work as well in diabetes. They don't migrate well to pathogen. Phagocytosis is less good. I've got data from my work showing your T cells don't work as well, different antibody responses. So I think it's a mixture of effects, but the diabetics who do survive use a different pattern of immune responses to the non-diabetics who do survive.
Could you tell us something more about Burkholderia thailandensis and other non-pseudomallei Burkholderias? We know about Cepacia, but the others that mimic melioidosis.
Yeah, I mean, thailandensis was, we used to think was Burkholderia pseudomallei. It's in the soil. And then, in fact, Nick can tell the story about, I think it's quite interesting. Professor White.
So the discovery of Burkholderia thailandensis was through soil sampling and identification on selective media of colonies that looked like Burkholderia pseudomallei, but they utilized the arabinose, the sugar arabinose, which pseudomallei does not do. And so from that, cutting a long story short, it became clear that it was a different species, but it's non-virulent. And there have been a few case reports, but I don't believe any of them, that they actually causes disease. In the mouse, it's about 10 to the 4 to 10 to the 5, so up to 100,000 times less virulent.
And it's interesting that the neurological neuromelioidosis, it's actually quite rare in Thailand, but much more common in Northern Australia. We don't really know why. So it's quite interesting that you've seen a case here.
there anything done about the duration of treatment for localized melioidosis and only oral therapy without giving initial parenteral therapy?
Yeah, you can use only oral therapy if you're watching it very, very closely under good medical care. And we're thinking about doing a clinical trial to compare the two in local therapy. It's a short course of intravenous versus oral only.
Okay, if there are no more questions, we will conclude this. Thank you, Professor Nicholas.